Chapter 45, Patients with Special Challenges. Part 2, Care of Patients when Abuse or Neglect is Suspected, and Care of Patients with Terminal Illness. Caring for victims of abuse and neglect is often difficult and very challenging. Groups particularly susceptible include children, dependent, older adults, and impaired adults. And it becomes very frustrating and very challenging because these are the people that society needs to take care of the most. Caring for these patients is often difficult because of emotional concerns, legal concerns, and regulatory concerns. Care is frequently complicated by interactions with possible perpetrators, and effective care must be provided while taking steps to protect them from future harm. Groups particularly susceptible are in this special population, and they need additional help, and they need society to step up and take care of them, not take advantage of their situation. Infants and young children are more likely to be victims of abuse or neglect. Abuse and neglect occur with varied frequency across race and socioeconomic status. Reported cases of abuses in the United States each year include millions of children and vulnerable adults. In most situations, the perpetrator is a family member. Abuse and neglect occur with varied frequency and can be committed by anyone with care, custody, or control of the patient, including parents, step-parents, foster parents, babysitters, and relatives. Abusive parents get little enjoyment from parenting and tend to be isolated. They have unrealistic expectations of their children. They try to control their children through negative and authoritarian means. They're afraid to or emotionally unable to ask for help, and there's a history of abuse. Most of the current abusers were abused or neglected as children themselves. Determination of abuse and neglect can be difficult when presented with factors such as poverty, religious beliefs about medical treatment, autonomy of mature minors, and potential victims with concomitant emotional or behavioral disorders. Physical abuse is the intentional act that results in physical impairment or injury. There's several different things that can cause this, anything that can cause physical harm. Throwing, striking, hitting, kicking, burning, biting are just a few listed. Consider physical abuse if a caregiver places the child in circumstances that create substantial risk of harm. Neglect is roughly 4 times more common than physical abuse. Children, dependent older adults, and certain vulnerable or impaired adults require assistance of caregivers to provide basic necessities. Neglect occurs when caregivers fail to provide such protection so that health and well-being are negatively affected. Signs are often subtle and require awareness to spot them. Sexual abuse and sexual exploitation include sexual contact, forced prostitution, inappropriate undressing, suggestive photography, forcing the victim to watch sexual acts or pornography. Almost 8.4% of reported child abuse or neglect involves sexual abuse or exploitation. Unfortunately, this is a very misrepresented number because many times these acts go unreported. Elder sexual abuse statistics are not readily available, but they are out there. Signs suggestive of sexual abuse include certain behavioral cues, genital trauma, presence of sexually transmitted disease. Emotional abuse impacts children, dependent older adults, and other vulnerable adults. Causes a substantial change in a victim's behavior, their emotional response, and their cognitive function. It may be verbal, which includes ridicule, threats, blaming, humiliation, or it may be nonverbal in cases where the caregiver ignores the victim or the caregiver isolates the victim from others. Caregiver substance abuse affects more than just the caregiver. There's laws that are enacted in various states to address substance abuse by a caregiver, including a fetus that's harmed by a pregnant woman using alcohol, illicit drugs, or other harmful substances, providing alcohol or drugs to a child, manufacturing or selling drugs to the presence of a child, becoming impaired by alcohol or drugs while caring for a child or other vulnerable person, driving while intoxicated with a child in the car, and allowing a child to become the designated driver for an intoxicated caregiver. Abandonment occurs when a child or vulnerable adult suffers harm because the caregiver fails to maintain adequate contact. Examples of this are leaving a young child at home to care for themselves, or allowing a child to wander unsupervised. A variety of behavioral cues and findings should prompt suspicion. Healthcare providers have a duty to recognize and report suspected abuse or neglect. Behavioral clues include things like the caregiver being intoxicated by alcohol or other substances, and the signs or symptoms that come along with that, such as agitation, slurred speech, bloodshot eyes, speech alteration, unsteady gait, or other unexplained abnormality. Other examples are when the caregiver tries to interfere with the physical examination of a child or vulnerable adult, refusing to allow a physical examination, looming over a healthcare provider during the examination, preventing a paramedic from removing clothing during physical examination, offering unsolicited explanation for abnormal physical findings, or interrupting or otherwise stopping the patient from answering questions about an illness or injury. In situations where you suspect abuse or neglect, do not confront a suspected perpetrator. Remember, your main goal right now is to remove the person that is being abused from the situation and get them the help and care that they need. You should report suspected abuse to the hotline and an ED physician. Pay particular attention when a caregiver provides history of present illness or injury or describes events leading to the EMS call. The story from the caregiver may not make sense in relation to the patient's age, capability, medical condition. The story may frequently change with each subsequent discussion, and the explanation differs significantly from the patient's explanation. Also, the caregiver may self-report facts highly suggestive of abuse or neglect. They may quote things such as, "I lost my temper," "I could not get her to stop crying," "I did it to teach him a lesson." Remember, anything that is subjective information should be written in your PCR. There may be a legitimate reason related to normal growth and development or a particular medical condition or mental health condition, not resulting from any maltreatment. Discuss abnormal behavioral cues or findings with receiving healthcare providers. Physical signs suggestive of non-accidental trauma include bruises on the torso, ears, proximal arms, and buttocks, closed head injury and absences of realistic mechanisms, burns, especially symmetric or without splash marks and ligature marks, bruise patterns resembling finger marks, shoes, or other common items, and seizure activity without prior history in an afebrile child. These are all images suggesting abuse. If you notice in the top right picture, this is actually called a stocking burn. The others are scalding injuries. This is the one on the top left is probably where the child was placed in scalding water with their bottom. Scalding or stocking burns is where they place the feet in scalding water. And then, of course, there's bruising on the behind. This goes beyond just punishment here. This is abuse. Benign physical findings include some physical findings that mimic signs of physical abuse. Ambulatory toddlers are prone to bruising or minor injuries as psychomotor skills develop. I've heard it said that you should look for bruises in various stages of healing on the child. If you look at my young child's legs right now, I promise I do not abuse my child, but she jumps off the couches and she jumps off the porch and she runs around and she's very active and she has bruises that are in various stages of healing. Mongolian spots are lesions that resemble bruises and are present at birth on many infants of Asian or African origin. Some healing practices, such as coining or cupping, create red marks or bruising. Healthcare providers in some cultures apply citrus or vegetable juices to the skin for healing purposes. If exposed to sunlight, phytophotodermatitis or redness of the skin may develop, resembling splash burns or other injury. EMS personnel may encounter benign physical findings suggestive of sexual abuse that may actually be caused by poor hygiene, masturbation, skin irritation from cleaning products, poorly fitting undergarments, or various infections. Management of suspected abuse or neglect is likely to evoke a powerful response in EMS and other healthcare providers. Emotions may undermine patient care and worsen the situation for the patient. Your assessment. Your first priority is to establish and maintain the safety of emergency responders. Request law enforcement assistance if the threat of continued violence is present. Your second priority is to provide optimal clinical care to a patient with suspected abuse or neglect. Life-sustaining intervention and prompt transport are the most appropriate treatment for critical illness or injury. If time permits, perform a thorough patient assessment that includes history of present illness, head-to-toe examination, relevant medical and psychosocial history, and balance the value of full patient exposure with the privacy needs of a patient who may already be traumatized. Make no assumptions regarding the identity of the alleged perpetrator or circumstances. The caregiver present may also be a victim of abuse. Use careful judgment when allowing a parent or caregiver to remain or travel with the patient. Separating an ill or injured child from a trusted caregiver can cause additional stress. If the caregiver is the violent perpetrator, the patient may continue to be threatened. Attempt to remain non-judgmental when providing care. Remain professional and provide the best care possible. Hostility toward the caregiver will only complicate the situation. With your documentation, expect that patient care reports and related documentation will be reviewed by law enforcement officers, social service agencies, and court officials. Documentation errors will undermine the credibility of the documentation and the paramedic. You should document all objective physical findings. You should document all subjective things that are mentioned or told, whether assessment of the particular body areas was accomplished or deferred, and the timing or time frame of the injury or event, or anything else that is pertinent or may be out of the ordinary. Mandatory reporting and legal involvement. Health professionals have a mandatory obligation to report suspected child abuse and neglect. If EMS personnel fail to report suspected child abuse or neglect, they may be subject to civil, criminal, or regulatory penalties. Many states have statutes specifically addressing mandatory reporting of abuse of older and other vulnerable adults. Consult applicable state laws and EMS regulations. Reports are made to the state or government social services agency of a particular jurisdiction. Titles vary but are similar to the Adult Protective Services, or APS, the Department of Youth Services, the Children, Youth, and Family Division, or others. Most states have central hotline telephone numbers available for abuse or neglect reports. Agencies evaluate the circumstances of a report and determine if an investigation is indicated. Investigation is determined by circumstances of the case, severity of the alleged abuse or neglect, and interventions range from providing support to an at-risk family to the removal of the victim from the home or facility. Alabama has mandatory reporting laws. Alabama Code 26-14-5 and Section 26-14-3, mandatory reporting. Who needs to report? Hospitals, clinics, sanitariums, doctors, physicians, surgeons, medical examiners, coroners, dentists, osteopaths, optometrists, chiropractors, podiatrists, nurses, school teachers and officials, peace officers, law enforcement officials, pharmacists, social workers, daycare workers, or employees, mental health professionals, members of the clergy, or any other person called upon to render aid or medical assistance to any child. When should you report? When the child is known or suspected to be a victim of child abuse or neglect, immediately by phone and follow-up in writing. Who do I tell? The Department of Human Resources and your local law enforcement agency. Be sure to report it to your supervisor and the receiving medical facility as well. Why should I report? Number one, safety and well-being of the child. Number two, you have an ethical obligation and a moral obligation. As a person who has taken an oath to care for your community, one of the big things that you should take very seriously is to care for those who need a voice, and it's the law. Immunity from civil or criminal liability if you do report. So that means that you can have a penalty for knowing something and not reporting it. Penalty for knowingly failing to make this report is guilty of a misdemeanor and not more than 6 months of imprisonment or a fine of not more than $500. The law has a 1-year statute of limitations. What should you report? The reports provided for in this chapter shall state, if known, the name of the child, his whereabouts, the names and addresses of the parents, guardian, or caretaker, and the character and extent of his injuries. The written report shall also contain, if known, any evidence of previous injuries to said child and any other pertinent information which might establish the cause of such injury or injuries, and the identity of the person or persons responsible for the same. Law enforcement frequently becomes involved and may respond simultaneously with EMS. If they do not respond simultaneously and you suspect abuse or neglect, you should immediately call for law enforcement. They may discover abuse or neglect while engaged in other law enforcement activities, and that's when they may call you. They may be requested by healthcare providers, EMS responders, or social service agencies. Law enforcement officers' roles in abuse or neglect include intervening when there is an immediate threat to the health or safety of a child or vulnerable adult, typically empowered to take custody for a short time until an appropriate agency can intervene or the immediate threat resolves. Conducting an investigation into potential criminal activity associated with suspected abuse or neglect. If a death results, cases are referred to the medical examiner for autopsy. EMS personnel may benefit from emotional support following cases involving suspected abuse or neglect. Many areas have trained crisis intervention personnel to help emergency responders manage enormous emotional stress related to these situations. I often think about reporting abuse like this. If I suspect abuse, I may be scared to report it because I may be afraid that I'm wrong. But what if I'm right and I don't report it? Ultimately, I've got to be a voice for the voiceless. I've got to be a voice for the ones that can't speak for themselves or are too scared to speak for themselves. Caring for patients with terminal illness. Encounters with patients with terminal illness. Terminal illness is a disease process that is expected to cause death within 6 months, verified by a physician. These conditions may persist for years as the health of the patient either fluctuates or steadily declines. Common terminal conditions include cancer, heart failure, pulmonary disease, liver failure, HIV, Alzheimer's disease, or amyotrophic lateral sclerosis, ALS, also known as Lou Gehrig disease. Many patients forego uncomfortable, invasive, and marginally effective medical treatment for their disease. Patients may decline aggressive medical interventions for otherwise treatable conditions. When treating these patients, be prepared to alter or forego life-saving interventions. Your actions will have a lasting impact on the family. Compassion, understanding, and sensitivity are most needed. Patients with terminal illness may receive continued medical care. Some continue aggressive medical treatment hoping for a statistically improbable recovery, and this is called curative care. As the disease worsens, however, patients may transition to comfort care, also known as palliative care. The focus changes to improving the quality of time left. Medical care continues, but aggressive, invasive, and uncomfortable interventions cease. Patients receiving this type of care frequently continue to receive analgesic medications, oxygen, IV fluids, fever treatment, and antibiotic medications. EMS is usually only called for supportive care in these instances. Patients with terminal illness and caregivers often know the best way to manage sudden discomfort increases. Pain assessment and management are often EMS primary tasks. Assess for pain using techniques depending on the patient's age, ability to communicate, and cognitive function. Obtain a history that includes the patient's use, effectiveness of, and adverse reactions to different pain medications. Your assessment should include your level of consciousness, vital signs, medical history, and pain medication history. Follow standing protocols or contact medical control to administer pain medications. Hospice treatment is a program and philosophy attempting to help the patient maximize the quality of remaining life. It provides social and emotional support. It treats discomfort with both pharmacologic and non-pharmacologic approaches, and it helps patients and families cope with impending death. Many of these patients, or all of these patients, will have some type of advance directive. Advance directives are signed either by the patient or surrogate decision maker. Please note that this is different than power of attorney. A surrogate decision maker is someone legally authorized to make healthcare decisions for the patient when that patient cannot make or communicate the decision himself or herself. Power of attorney is someone that handles the estate for someone that is no longer able to handle their finances advances in a state. Most of the time, power of attorney and surrogate decision maker for healthcare are the same person, but you do need to make sure that you delineate between the two. Forms instruct healthcare providers on medical decisions for the patient when the patient is incapacitated. A form can specify which medical interventions are authorized in particular situations, who is authorized to make decisions on behalf of the patient. Patients with decision-making capacity can revoke a prior advance directive. Contact medical control if there's any question regarding documentation. The patient's surrogate decision maker is contradicting a written advance directive. DNR orders, or do not resuscitate orders, are physician orders instructing healthcare providers to withhold some or all resuscitation efforts in the case of respiratory or cardiovascular collapse. Of note, a DNR is not a do not treat order. Do not give analgesia, do not give oxygen. Those are all things that you should do in the case of a patient, even if they have a DNR, to provide comfort care. DNRs may be generic or specifically discuss what methods are indicated or withheld. State EMS agencies may require a specific DNR form to be provided. Other possible indicators of DNR status include wristbands and bracelets. EMS regulations may specify if the DNR status symbol is sufficient to withhold resuscitation efforts. Consult EMS regulations for a particular state for specific requirements regarding DNR orders and advance directives. According to the American College of Emergency Physicians, ACEP, tattoos are not legal advance directives, in part because they do not include a witness or notary. That's bad news for the person who thought he had his bases covered. This concludes our section on abuse in patients with terminal illness. In our next section, Chapter 45, Part 3, we're going to discuss care of bariatric patients and care of patients with communicable diseases.